hits different places in the central nervous system. You need to show dissemination of the disease in time, meaning that the disease is evolving over time and is hitting the CNS at different phases. And third, you need to exclude alternative conditions that may mimic MS clinically or radiologically, for instance. And you may do this through clinical assessment, through the use of laboratory tests such as CSF analysis, as Juliana just said, or you may do this using paraclinical tests, which is evoked potentials, CT scan in the past, and now more recently MRI. You have seen how MRI has changed the history of Juliana. She has to wait 20 years to have a diagnosis. This is not the case anymore, and you might have early treatment with an early diagnosis, and the early treatment is very useful to reduce the risk of progression later on. So why paraclinical tests in addition to clinical assessment? I already discussed this, to increase diagnostic confidence, to have a diagnosis earlier, which means a better therapeutic approach earlier and perhaps a better evolution later on in the course of the disease. As you might know, I don't know much about MS in general. I just know a few about MRI. So my main focus from now on will be on magnetic resonance imaging, which is important, as you just heard from Juliana, in terms of diagnosis. And the MRI is so important because it is very sensitive in detecting MS lesions. This is a post-mortem brain from a person with MS scanned 20 years ago or more by Don Petty. And such an image is so clear because if you put it close to an histopathology assessment of the same slice, you can see that you can have a one-to-one correspondence of lesions seen on the pathology preparation with what you can see on MRI. So this is why MRI became so popular, and it is so important for making a diagnosis of multiple sclerosis. So with this background, we can review together a few typical MR findings you can see on MR scans of a person with multiple sclerosis. And first of all, these are typical MR images you might be familiar with. This is a proton density weighted scan where you can see many lesions, especially around the ventricles. And this is a T1 weighted scan after gadolinium injection where you can detect lesions that enhance after gadolinium administration, meaning that these are new lesions, just newly formed. So with just these two images, you have a flavor of disease dissemination in space because you have very many lesions around the brain, and some of which are new, some others are old, so you have also a flavor of dissemination in time. I told you that there are some typical aspects of MS lesions. First of all, their location. Lesions are frequently periventricular, but they also can be seen in the infratentorial brain. They can be seen on sagittal images in the corpus callosum, and they are also typically seen in the U fibers close to the cortex. They have a typical shape, which is usually irregular and ovoid, and the distribution across the two hemispheres is asymmetric because the disease hits the two hemispheres in a random way, and the evolution of the disease is very variable. So if you get different MR scans at different times, you can see lesions disappearing close to lesions that comes up as a new lesion. These are just a few images to readdress these issues. This is typical periventricular lesions of a person with multiple sclerosis. This is just to remind you that there are flare sequences available which allows to suppress the CSF signal so you can see lesions even better and make diagnosis easier. And this is just an example of lesions in the infratentorial brain. This is the pons with a very big lesion and few other lesions in the cerebellum. This is what I said, lesions in the corpus callosum, such as in this case, you have very many lesions in the corpus callosum, which is typically damaged by multiple sclerosis because corpus callosum has a lot of myelin, but usually is not damaged by vascular diseases because it has double vascularization from the two hemispheres. And this is the case of the U fibers, so fibers placed in the subcortical areas involving this fibers which have a typical U shape. And again, these are typical of MS because there is a lot of myelin there, whereas this is not the case for vascular lesions because, again, there is double vascularization coming from the parenchyma and from the meninges. So, of course, there is not only the brain, there is also the spinal cord in the CNS, and spinal cord is also involved by multiple sclerosis. This is a case, again, of a patient with multiple sclerosis and a few lesions in the cord, as you can see down here. There are a few tiny lesions in the cord that can be seen also axially, such as in this case, you see there is a typical MS lesion. And there are some typical features of MS lesions in the cord. I will summarize this very quickly. Lesions in the spinal cord of MS are very small. Usually they are not longer than 2 vertebral segments, as you can see here, and they don't occupy the entire cord cross-sectional area. The optic nerve is another site where MS lesions can be seen. This is a normal optic nerve. The optic nerve looks gray in these images with the CSF which looks white around the nerve. If you have a lesion, everything becomes white, and you have this completely white optic nerve, which means that you had optic neuritis. So again, something which is not only seen in MS, but which is very typical in the diagnostic workup. So with this quick review of typical MR images in MS, we might ask ourselves which is the present approach to do diagnosis, to make a diagnosis of MS using MRI. I'm sure you are all very well aware of the recent classification of multiple sclerosis published by Pullman and co-worker in 2005, where there are a few criteria that has been suggested to make a diagnosis of MS using MRI. I will go very quickly for this because this is pretty technical, but you need to show dissemination in space using MRI, you need 3 of the following 4 items. So at least 1 enhancing lesion or 92 lesions if you don't have gadolinium enhanced scans, at least 3 periventricular lesions, at least 1 subcortical lesion, and at least 1 infratentorial lesion. So 3 of these 4 is enough to show dissemination in space, so to fulfill the first requirement to make a diagnosis of MS. So and this is an example of this. You have a few lesions around the ventricles. 1 is also infratentorial. There are few lesions enhancing after gadolinium injection. So this patient does fulfill the criteria for MRI to show dissemination of disease in space. The new classification also considers spinal cord lesion as a part of the diagnostic process, and the spinal cord lesion is considered equivalent to a brain infratentorial lesion and can contribute along with individual brain lesions to reach the required lesion number. So any lesion in the spinal cord contributes as lesion in the brain to the required numbers of lesions to show dissemination in space. And this is just an example. Let's imagine this patient don't have this lesion, so you might show the presence of additional critical lesions to make a diagnosis in the spinal cord, such as in this case there are at least 3 lesions, 1 of which is enhancing after gadolinium injection. I wish to remind you that this criteria might be simplified if you have CSF. In fact, if you have CSF oligoclonal bending, you just need 2 subclinical T2 lesions to make a diagnosis, such as in this case with very few lesions. There are just a few lesions around, but oligoclonal bends allow to show dissemination in space according to this criteria.